Okay, thank you everybody for attending. We're just going to give another moment to get started for our presenters. Okay. Well, thank you everybody for being here for today's presentation. My name is Joe Simonetti. I'm the Director of Education for the Firearm Injury Prevention Initiative at the University of Colorado Anschutz Medical Campus. The Firearm Injury Prevention Initiative strives to prevent firearm-related injuries and deaths in homes and communities across Colorado and the U.S. through collaboration, research, and education. Our approach is rooted in recognition of a common goal of health and security, respect for and consideration of a wide range of views and experiences, and engagement of impacted communities and those with lived experiences. Today's presentation is about coordinating community-based care with forensic nurse examiners. We'll be spotlighting a case review. Just a couple of notes for those who are in attendance today. There is no chat feature in today's presentation. However, the Q&A feature is open. So if you have any questions at any time during the presentation, please include that in the question and answer box, and our presenters will either get to that during the live presentation, or there will be time for question and answer at the end of the session. At the end of this session, we will also include links to sign up for future webinars as well as our newsletter series. We have a lot of presenters here today from two fantastic programs. So I'm going to give just brief introductions of the programs themselves before I pass it off to our presenters to introduce themselves and tell you a little bit about their work. First, the AIM program and REACH Clinic team provide community-engaged hospital violence intervention, recovery, and support services for individuals impacted by violence, particularly firearm-related injuries. And the UC Health Forensic Nurse Examiner program provides specialized trauma-informed medical forensic care for patients affected by violence, abuse, and assault. With that, again, I want to thank you all for being here today. I'm now going to pass it off for our presenters to briefly introduce themselves. I'm going to start with Dr. Kennedy, who is the research director for the UCH Forensic Nurse Examiner program. Dr. Kennedy?
Hi, everyone. As Joe said, I'm Dr. Kennedy. I'm an assistant professor in the Department of Emergency Medicine. I'm the research director here at the Forensic Nurse Examiner program. Really lucky to work with this team here. I guess we'll go kind of across here. We're all here together in the room and in the hospital right now. I have to my left here Erin Oshman, who is our nurse manager.
Hi, happy to be here.
And then do you guys want to introduce yourselves?
My name is Lauren. I'm part of the forensics team here as one of the nurse navigators with the program.
My name is Christina Natzos. I'm an emergency medicine physician. I'm also the medical director of the forensic examiner team.
And my name is Alexis Clendenin. I am the associate nurse manager program.
And then we'll go ahead and hand it over to the AIM and REACH team. I'm seeing several faces here. I'll maybe hand it over to Jenny first and let you guys take it from there.
Sure. Hi, good afternoon. My name is Jenny McCarthy. I am the director of the REACH Clinic, and I'm also an assistant professor in the Department of Surgery at the University of Colorado School of Medicine and a faculty member through FIPE.
And I'm Johnny Williams. I'm the executive director of Denver Youth Program, which houses our AIM program, our GRASP program, GRASP Enterprises, and a couple of other initiatives that we use to provide opportunity for young people struggling with the trajectory of life that they may be on. Happy to be here.
Hello, my name is Felipe. I work with AIM as a VPP for Violence Prevention Professional. I'm also manager of GRASP.
Hi, my name is Jackie. I am a violence prevention specialist here at GRASP with the Denver Youth Program.
I'll turn it back to you.
Sounds good. I think these first two slides are about your program, actually. do you guys want to give a quick overview? I can kind of toggle through. There's two quick slides here if you want to. Sorry to ping it back to you.
No, perfect. That's great.
So our AIM program is, started organically several years ago when the community was having a situation where the trust was broken between them and the hospital. And we kind of sat with the community to talk about what is it that you need to rebuild the trust with the medical system that is deep to, oftentimes save your life. And the trust issues were, they don't see me. Can they see me? So we started a program that we brought people into the hospital that have lived experience, that knows the community, that are part of the community, that can articulate between the community and the hospital staff at times when trauma is going on in the community. Like what is HIPAA and what does the family need to be given notice that a loved one may no longer be with us, or how do we get an opportunity for a family to see their loved ones that may be still in the emergency room without violating HIPAA, just being able to navigate those waters. So now we're in 5 different hospitals. We have our staff that is bedside specialists and violence prevention professionals that navigate that from the scene of the crime all the way to the Reach Clinic, which Dr. McCarthy is the director of, which is the aftercare clinic that has services that are provided for wraparound services to prevent re-injury.
And I'll talk a little bit about the Reach Clinic, but first, if Felipe, do you want to tell us a little bit about what happens when a client presents to the hospital with an injury?
Yes. So there are a couple of ways that we do see a client. One would be we carry a trauma pager phone that would go off, and then all this alerts that there is like a GSW, and it give us if they're male, female, age, and then that would be our first response. And so we would have at least 45 minutes to get to the emergency room. Then as we get in the room, we'll do a check-in. Usually I will go with the head nurse, check in, let them know who I am, and I am wearing my AIM shirt as I'm there. Then my first approach is just to see the victim that's on the bed itself. And as as funny as it sounds, my first question is, how you doing? How you feeling? Where you at? And usually, I always get different responses, but just letting the victim know that I'm there for them. And then from there, that will start the whole process of being a violence prevention professional. And the second one is we'll monitor the boards. So we will give in a day, and we'll be at the hospital that day, and we'll do our rounds in the ER, and we'll watch the Epic board and see what's coming in. And anyone from 14 to 45, that's our demographic. Anyone, it could be like a loss of conscience or an assault. Sometimes it's a laceration. I'll get a little bit more into it and see how this person was lacerated. And it's really just being there at the right time.
Thank you. And then we follow the patient and work with their family in the hospital and then post-discharge. So post-discharge, ideally, when Felipe sees a patient at the bedside and the family would say, hey, we want to see you when you leave the hospital. Come in, we'll make sure your wounds are looking okay. We have the ability to provide wound care here on site. We are partnering with the Department of Surgery to be a site of practice so that we're able to remove bullets down the road. That's a whole separate webinar. We look at mental health care and access. We know that wait times and cultural and linguistic barriers are often present for our clients, and we want to make sure that that holistic approach to healing is incorporated into their care. So we start that here at the Reach Clinic. We aren't intending to be in substitution of or in lieu of medical care or follow-up care. Instead, our team, Felipe, Jackie, Johnny, myself, we would be in a position to accompany patients and clients back to those appointments, make sure they're scheduled, make sure they know how to get there, make sure they feel comfortable going back. And then some of those complementary services through wraparound care, including the ones listed on this slide, but also through the idea of referring out to services that we don't provide in-house. And the long-term goal really is to connect people back into primary care as prevention. So restore that trust that might have been broken before or throughout this process in healthcare, to attend to all those symptoms of trauma that are present, and then connect back into the healthcare system over time.
Yeah, and the overall aspect of that trust, it goes through the whole community. So our prevention and intervention teams work together along with our AIM team and our REACH team. And we definitely do have research that says like it does work. There's a situation where we had a young lady that was attending one of the schools that our prevention team works at, and then for whatever the reason, community trauma happened and she ended up getting shot. So our AIM team saw her, our intervention team saw her at the gunshot at the scene. And when she went to the hospital, our AIM team saw her at the hospital. And when she was released from the hospital, they took her clothing because it was evidence, and she came directly to the REACH clinic and not only got clothing, but she was able to get other resources that she needed. And then her appointment back at the doctor was set up the same day that she was here. So it's an overall wraparound services to make sure that re-injury is prevented.
And everyone who's injured receives a brick box, and that's what's behind us here that Felipe has. And these have essential supplies for the first few days after injury. It also has contact information for the REACH clinic. So when someone sees an AIM outreach worker or comes to the REACH clinic, they have those supplies they need for that immediate care. But then also when they come in to be seen, we provide supplemental supplies. So Felipe has that. And this is from the BRIC, the Bullet Related Injury Clinic in St. Louis, Missouri. And I think that's enough of an overview for now, perhaps even too much, but thank you for dropping the links in, Micaiah, and we'll pass it back over.
Awesome. Thanks, guys. So I guess to quickly go through then what the forensic team does. So before we dive into what our program does, maybe we'll first start with what a forensic nurse examiner is to begin with. Really what a forensic nurse examiner is a registered nurse who's specifically trained and specially trained to provide trauma-informed medical forensic exams, which are basically we will get a thorough history and understand exactly what happened to the patient. We'll get a full psychosocial history as well, and we'll do a full head to toe exam and try to really understand really what this patient is presenting with. We'll use evidence collection as appropriate and needed. We'll make sure that that patient gets connected to resources before they leave the hospital. And we really work with these multidisciplinary teams to make sure that this patient gets the best care that they possibly can when they come to the hospital. And we will see primarily patients in the emergency room, but we'll really see patients anywhere in the hospital. And so, and this can be for any kind of violence, assault, or abuse. So it can include domestic violence, intimate partner violence, child abuse, elder abuse, trafficking, physical assault, sexual assault. And so we really will see the whole gamut of what patients may present with. And then what happens when you come to see a forensic nurse? And so during that medical forensic exam, we'll of course start with just explaining who we are and what we do and getting that informed consent piece down. I just realized I might have been taking your son. I'm sorry. I should hand it over to you. No. This is our active person. I'm so sorry. We'll let you go for this particular side of it all dive in. I'm so sorry.
Totally sorry. Yeah, so one thing I want to emphasize for forensic nursing, I think one of the most common beliefs is that we only work with survivors of sexual assault. Every program is a little bit different. The program that we have here at UC Health, we cover the Anschutz campus along with Highlands Ranch. Is that it's a very comprehensive program. So like Rachel was saying, we see really any patient that has been affected by any type of violence. So I think that's a important thing to note for what our program offers. So every medical forensic exam is going to look different because we are tailoring to what the patient in front of us wants and needs. Whenever we are consulted on a patient, our ultimate goal is to understand what they are hoping to gain from seeing us and give that power and control back to them right away to see how we can best support them and what they're hoping to get. And there's a variety of things that we can offer. So whenever we're consulted, we meet the patient and really understand, the situation and offer them our exam, but ultimately it's up to them. They do not have to participate in our exam if they choose not to. We can also provide resources only. So we get an idea of what their goals are and can consent the patient from there. We also, big part of what we do is work with community advocates that are available to us. There's a organization that has in-person community advocates for survivors of sexual assault, and then we do our best to get them connected with programs like AIM and REACH to continue their progress and have the appropriate support after being discharged from the hospital. A huge part of our exam is taking a detailed history if they're choosing to participate in the exam. So we're taking verbatim from the patient what happened during the incident. And because we're taking that verbatim, that can be taken in as evidence into court if the patient's not able to testify. And then we also do a thorough head-to-toe assessment to assess for injuries that we find. We have a very specialized camera where we can get really detailed photography to have the patient's injury documented. If it was a sexual assault that was being reported, we can do a detailed anogenital assessment. We can also collect evidence if the patient is choosing to do so. So that would look like collecting swabs. So we're able to do that for a strangulation situation or sexual assault. We can also collect clothing if the patient would like us to do that. And then depending on the exam that we have, we can also give medications specific to our sexual assault exams. And then we like to offer the opportunity for our patients to be followed up by our team. And as a navigator, follow-up phone calls is something that I do to make sure that the patients were actually able to get connected with resources if they need help navigating through the law enforcement process, getting connected with different advocates, things like that. So we try to be, we're very thorough in our exams and how we like to support our patients.
And then this just kind of demonstrates, we really are kind of that, as like AIM and REACH do, they bridge patients from that hospital to the community. We are likewise trying to connect our patients directly back into the community. So there's many ways that somebody may come into our care. They may come through somebody who recommends them to come to the forensic program. They may seek us directly for an injury or for a concern. Law enforcement or somebody else may bring them in out of their concern. But regardless, when they get to us, we are able to get them a consult with a navigator. That's even better. We can make sure that they get tailored safety planning and really coordinated care and resources for that person's needs. And there's all sorts of wonderful community partners that we get to work with. And we were really excited to be able to continue and build on the partnership and collaboration that we have with the AIM and REACH team, particularly through this case, which I think was a really great example of how these partnerships grow and how we're really able to better work together to support these patients that we all work with. I might hand this back over first to the AIM and REACH team for just maybe how you guys first got connected to the case, and then we can step in for when you start handing it off to us. Does that sound like a good flow here?
Absolutely, thanks.
Yeah, so this case here, we received a call from an outside hospital we've been working with, we just started working with, and they just gave us a couple details of a female, gave us an age, she was GSW, and she was ready, was seen in the ER, she went through surgery, and they just wanted to bring someone in to talk to her. One, she was only Spanish speaking, she also was a newcomer, so they just wanted to make sure that she had some kind of type of resources leaving. So I was the person who was responding, as I went to go speak to the victim. Um, I did take in mind that, one, not knowing what the assault was about or not knowing anything, I just went in really calmly, peacefully, speaking to her. And when she knew I spoke Spanish, she definitely made her feel better. And then we kind of got into what brought her to the ER. And then from there, I was starting to, put in all the facts that happened. and then let her know, like, okay, this is how we perform, this is what we got, these are the resources that we do have, and this is how we could support you. And, some of the things that I was asking her is like, do you have the case number of the incident? Didn't really talk too much about the incident because I didn't want to re-traumatize her. And then from there, I also let her know, like, you comfortable speaking to me? If not, I could bring a female staff in here, and she was okay with me. And then from there, it's like there's gonna be a follow-up, and this follow-up could consist of these other people calling you, but mainly I'll be working with you. And then after that was done, I came back and I also asked her for permission if I could share her story or what has happened to her to with my team, which she agreed to. So once I got back to my office, I did connect with Jackie, who's part of the team, and Jackie was awesome at what she does, and she's the female aspect, and I was able to talk to her as well. And then from there, we brought her to the Reach, and then because of the language barrier, I wanted to make sure that she completely understood what I was saying. So I had Jackie in the room as well, and also she was shot in the chest, so. I didn't want to make her feel any kind of way. So I had left the room, so I'll let you ladies be, and then Jackie could take over from there.
Hi, yeah, so I met the client here at the Reach, and I was pulled in to be able to speak to her in her native language, and help with any other resources that she may be needing or resource navigating. That day I got on the phone immediately, I can't remember if it was with, one of the nurses. We got, in touch with one of the nurses and we set up an appointment, I believe for the very next day. So then I spoke to, can't say the client's name, right? Sorry. I spoke with the client, thank you. And I was like, hey, do you have transportation? Can I help you? How can I help you? And she's like, the way the injury was, she couldn't be like in a lower or sitting car or whatever. And I have a small car. And so Jeannie was able to use her car. So I transported her from the Reach. Or I went to go get her from her house and I transferred her to the hospital, and then that's when I did soft handoff to the nurses at the hospital. So thank you.
Yeah, so the biggest thing that I want to emphasize is how incredible the Aim and Reach team did with this patient, because they truly provided trauma-informed care to this patient along with incorporating that cultural care. And I think that's one of the biggest pieces that set our team up for success after that handoff, because right away she trusted us more, because they really did such an amazing job with this case. So hats off to your team. So yeah, I was able to do a phone call with the patient before they transported her over. And my initial understanding was that this, a GSW occurred, and then really over the phone was trying to get a better understanding of some of the complexity of what was really happening here, and determined this was intimate partner violence. And without during the exam, a huge piece, as I stated earlier, is taking that history. So not wanting the patient to have to relive that scenario too much initially, but was able to get an understanding of what was going on, and more thoroughly explain what we could offer if she did choose to come over to the hospital and participate in an exam and work with our team. And she felt comfortable doing so. And once she got here, like I said, I just felt like she was much more trusting of us because of how the Aim and Reach team handled the situation and how they handed off. And we were able to get her connected with some other resources as well, and talk about more detailed safety planning, if she had a safe place to go. And really from a holistic perspective was this was a success in being able to provide an exam for the patient and have the things documented that she wanted to have documented. And also, if I remember correctly, after um, talking further with the patient, I think from a law enforcement standpoint, there was miscommunication about what happened during the incident. And we are not law enforcement in any way. We are truly a medical service that we're providing to the patient. But law enforcement, we do coordinate with them in certain ways. So we were able to initiate getting things cleared up and also getting her set up with a victims advocate through law enforcement as well. So it was a really big success for this patient and her safety and her health.
I just want to say thank you, Lauren, for that. You brought back some. I forgot to mention. So one of the things is also is a lot of times these clients that come in, they don't even know what a forensic exam is, right? And us talking to and explaining that to her, definitely, I think it made her feel important. That her story does matter, and also with the victims advocate. So that always having that's another way we do advocate for our clients or patients is trying to get them a hold of victims advocate and telling the true story. I know one of the first responders on the police side was a male. And I don't not putting words in his mouth or what ideas was going on. And I think that definitely affected the situation. And also, I wanted to bring up that when she was brought to the Reach, we do have a clothing bank. And so we were able to provide her at least a month's worth of clothing because, with her situation, one of the things is that they wanted to put her back in the apartment where it happened. It was like, no. And so we were like, okay, we got you, we got your back. And so also we're like 24-hour response, right? When you feel like anything's happening, we'll show up. And I just wanted to mention that as well.
Yeah, that is wonderful. And I think this is, I feel like a real win-win for us in the sense of a lot of times patients come in and it's because they were brought in because that was the only choice they felt they had. They don't really know maybe what they're walking into. If there's a lot of scary unknowns, it can feel very daunting. And there's a beauty in like us being able to work together beforehand and really communicate and do that really warm handoff and also continue that support even after they leave us, which is another big challenge for hospital-based care that I feel like even Reach have really championed, just being able to extend care far and beyond the hospital, which is again just a big win for us from a trauma-informed perspective, being able to get resources. And I think the slide is kind of a shared slide in the sense of there was just some things that worked really well. And I'm sure there were some lessons learned. We talked about, some communication things. So I think a lot of it for the most part was fine-tuning really this pathway of how we can better connect patients to care and how we can better support you all. And I think I've had ongoing communication on how we can better inform our practice. I think some big things were like communication was really clear. There's a quick response. It's, your warm referral process and cultural care really stood out. And then also really this patient, I don't feel like was ever left to make those decisions fully, solo. I think there was a lot of support to be had all the way around, which was a big one. And then, I think we hope to continue to establish, ongoing care for other patients down the line. And it was a good model for how we can learn from all of this. I don't know if you all have other thoughts too on things that worked well or lessons learned.
Oh, go ahead.
No, go ahead, Jenny.
No, I think thank you for that. And I want to say that we want to talk about this together. And I think this was our first shared case and everything went well. And so I think it was an interesting exercise instead of troubleshooting and saying what went wrong, to build out a system, we were able to step back from this one and say, what went well? Like what made this successful and move so quickly? And I think part of it is, Rachel, you getting us all together and saying, there is a a challenge to getting people to come back to access care. And I do think that we see that with patients injured through violence as well, more broadly, the patients that our team responds to. So to anticipate the possible barriers, everything from language to transportation to Felipe making sure that she was comfortable talking with him versus talking with a female colleague, knowing when to just step out and, and to turn it over, having our culturally responsive clinicians who come to clinic and look at wounds. And so just being able to go from most urgent to most needed, because then the trust is there. So you all saying that having that trust established with the AIM team first really is that goal, because we want to make sure that trust or lack of trust isn't a barrier to needed care. And so looking at that, 5th point, the barriers to follow-up care from a hospital perspective, I think having that community space that doesn't look like a hospital, doesn't feel like a hospital, but then having clients be accompanied back to the hospital, because that is where most care can and should be delivered for follow-up, is that critical missing piece. And so we've valued and we've appreciated the partnership. And I know that we're continuing to work out some of these processes so they aren't a text message to say, hey, remember how we talked about that thing? Can we do that right now? Can we make that happen right now for a client? And then also to applaud that you're responsive, that your whole team is responsive, everybody from the top to the bottom, and here as well, Johnny being able to orchestrate care on our team and make sure that the missing pieces or the necessary pieces were in place. I think it isn't a sustainable model of care, but it's necessary to get the model designed. And again, to work from what worked well to what needs to be the system going forward.
Yeah, and I would just like to add that I was in a meeting earlier today and I mentioned it, is that even when we don't have the resources in our own agencies, that we find the resources so that we don't just leave our clients without something to do or to go. And we noticed that you guys did the same thing by finding other resources for them outside of what your wheelhouse is. And that's always the goal, is always connecting our clients to the resources that they need, even if we don't have them in-house. And we really trusted those relationships, that we knew that they were going to be in good hands. And then even if we had to go back and backfill a need, that we were able to have communications around that.
Also from this first case, now we have another one that just came up. And so now knowing about F&E, I was asking these questions to the victim, the client, like, have you had as forensic nurses exam yet? And she's like, what? And so this person was passed to 2 different hospitals, which that hasn't been brought up. So it might have been the lack of communication or not misunderstanding or the wordage, right? So now we're gonna be in the process of setting her up for the F&E exam, so we can get those documents set up for her, so when she does talk to her victim's advocate, she's prepared. Because it's always a learning going process, which I definitely I think it's amazing.
Yeah. I think one of the biggest areas that one of the things that really helped this be successful is that the AIM and REACH team, because they were able to get the patient directly connected with us immediately while she was in the support of their team. And when a F&E is able to speak directly to the patient very quickly, we're able to provide all the details that the patient needs to know. And we do a lot of community education to, help other avenues understand what it is we do. But, I think without that really detailed explanation and helping them understand that they have choice, they have power. We are truly medical. We do not work with law enforcement, and just really help the patient understand what it is that we can provide. It can make it feel less intimidating and less scary. And, something that we do within our program is, an emergency room nurse or a provider might give a little detail about what we do, and a patient may say, oh, I don't you know, I don't want to do that or I'm not interested. And then, you know, when we go in there and explain things a little bit differently or more in detail, then a patient may be more likely to want to participate or be more open to resources that we can provide them. So I think immediately being able to talk to the patient was extremely helpful in fully understanding what it is we can offer.
Just also the flexibility of Reach Name Team. I think you guys, you were right, Jenny, it was a text message, but I think we all were all hands on deck. And I think that was the team spirit that we all walked into this with. And like you guys say you have another case, you know, we're all here literally right now. So just let us know. But I think it really, you know, paved the way for a lot of future collaboration and like being able to handle this and at least know kind of how we all work together or how we all work separately, but then how we could continue to work more and more together for these patients. So I think there's a lot of good things ahead. So yeah, let us know if there's another. So be sure to coordinate with you guys.
I just want to say something real quick. I was able to, we had lost contact with the client, but I was able to reach the client because I knew this was coming up, and she was just grateful for the work that started initially, you know, with Felipe all the way down to the nurses. So she says she's doing really good. So thank you so much for taking good care of her. You know, passed after we, you know, dropped her off with you guys, and then she came back over here, I think, one more time, and she was really grateful for that, and she remembered you guys, so thank you.
Amazing. We never get updates like that. So
Yeah.
thank you. That is a huge deal for us to be able to know that our patients are still doing okay months later. That's a huge deal. Thank you. I think we only have like one more slide. I see Joe pops up. I think a lot of our ideas moving forward are just to formalize this process. I don't know, I didn't really schedule who was going to do this particular slide, but I think again, it's an all hands on deck, and Ginny and I have been communicating and we want to see it happen, as well as Johnny and Christina and managers and VPPs, nurse navigators. We have just an incredible team who I think you all want to see this happen. And so formalizing it in paperwork, but then also just kind of figuring out what those communication channels could and should look like. That's what I personally think of, you know, what we've talked about and what I think feels like the next ideas moving forward. I don't know if you all have any other thoughts though, in terms of other things, but, and also just continuing to educate each other, because we do a lot of collectively education. And so learning from each other and sharing that knowledge. I'll stop.
Well, I think that's great. I don't have anything else to add. I think it's just continuing to educate and coordinate and be in good communication with resources that are truly making a difference.
Yeah, we want to make sure you guys feel supported. So
Can I add one thing? Is it okay?
please.
I think one thing that also helped with this patient also was that we met with the AIM and REACH team prior to this. So we were able to, even without having a patient in mind or a scenario in mind, we were able to visit the AIMS facility and area so we could see what it was like there and then just get to know you all. And I think that also helps, just that outreach, even without knowing specifically who this would work for. But when the opportunity arose, that was a direct, oh, I know which partner can help with this and make that connection. So I think that also helped too. Mm-hmm.
Yeah. I think that's really it there. Unless you guys have something to add there at the end. I think we have a little, oh, this is maybe an over slide, but you're always welcome to work with us. I think the same goes for English, but if you guys want to reach out to us, we have probably too much contact information on the slide, but now you have it. You have Johnny and Jenny as well as all of us here. And you're welcome to always reach out to us if you ever want to collaborate or learn more about our programs. We're always, you know, we're active advocates for what we do and how we can help patients. So
Okay. Well, thank you all for that presentation. Again, appreciate everybody being here today. Just a note to any attendees, if you have questions, because the chat feature is not enabled, you can add those questions to the Q&A and we can go through those. It sort of struck me, I really appreciate you looping it in and providing some feedback from the perspective of the person who was at the center of all this. And it's a perspective that we don't often hear enough about. And it made me realize, or it kind of reinforced what I had realized throughout hearing you all speak, is like what a tremendous resource you provide as collaborative teams. I'm curious, how common is it for a patient to be able to encounter not just an F&A team or a team such as AIM or in the Reach Clinic, but a team like that combined? Like, how common are these services nationally? I don't expect a statistic, but I'm curious to know whether or not this is common or an uncommon level of care for somebody to receive after an injury like this.
Think I can speak for everyone on our side at least. This is pretty unusual. There's not a lot of forensic programs in the country. And certainly I think AIM, you guys are the only HFIP, right, in the state, in the whole region. Right? So I think this is a pretty uncommon collaboration and opportunity.
In the state of Colorado, UC Health is the only hospital that offers comprehensive F&E team for adults. Children's offers it for kids. There are a few other F&E and SANE programs, but they don't treat all patient populations. So, yeah.
And I would just add to that, those were excellent statements to back up the fact that because you said nationwide, in other cities and states, even if the services are available, they're not communicating on the level that we are. They have not created that relationship and that partnership. And that's where the gap is that there's places that have all kinds of resources for our clients, but they're not talking to each other, which is why with F&E, I applauded them, because even after they've reached the limits of what resources they had in-house, they still reached back to us and reached out to other organizations to create the relationship to make sure that the patient was whole at the end of the day, right? Rather than, oh, we did our part, now we're done. And that's what happens in some of the other states, is that even though they have the services, they're not connecting each other, they're not communicating, and they're not having a level of concern to whether or not the patients are complete at the end, as long as they do their part and check their box.
Yeah.
And I think nationally, not to speak for F&E fully on this, but I think that at least in the AIM world, the HFIP world, this post-discharge model of care that we're working with in the Reach Clinic, it's similar to a trauma recovery center model, but it's slightly different because of that focus specifically on healing from injuries due to violence for the individual and for their family and her social network. And so that the holistic care that Johnny's talking about, I think the community-based model of care, or this holistic model of care, multidisciplinary model of care in the community, is unique in our world for that follow-up care. Case management happens across many HFIPs, but to have co-located services in a geographic place is different. And I suspect that's true for F&E to an extent too. And that's kind of why this partnership started to develop.
Yeah. And like I said, I'm actually one of the nurse navigators with the forensics team. There's currently 3 of us. We are in a grant-funded position. We are the first forensic nurse navigators in the country, is my possibly. It's very, very a unique position, and I think that with our sole responsibility being safety planning with the patient and getting them connected with the correct resources. While our forensic nurses are in an exam, in other programs, they, if they're tied down in an exam, it'd be way more challenging to be able to do what we did with this case. And I think it speaks to the success of our nurse navigator position. I think that we're just able to do more follow through and really help narrow down for our patients what to focus on when leaving the hospital. Because I think a lot of programs, they have resource sheets, but I can tell you for someone that is in a traumatic state, they're not able to process things and they are very overwhelmed. So to look at a giant resource sheet, they are probably not going to be very likely to reach out to resources. So we're able to kind of narrow down for them, here's the number one resource I would focus on, and, or, top three, so that we can eliminate as much overwhelm for these patients. And have that follow up to make sure they understood what we educated them on here in the hospital, and then reminding them of the resources available to them, and helping them through that process with follow up.
And I'll also just add in there too, I think that the importance of a warm handoff cannot be understated, not only because of what Lauren was talking about and how complex it can be navigating these situations for somebody, but if you can tell a patient, hey, I know this organization, I've worked with them before, or, when we send patients to shelters, hey, I've toured this shelter, it's a really nice place, and you've already built some of that trust and rapport with the patient, that can go a long way in removing some of the uncomfortableness of the unknown for them.
So pretty unique, Joe, I'd say overall.
Yeah, when I asked the question, I had initially been wondering nationally how uncommon is it to have sort of a collaboration like this, but it completely escaped me that it seems like it's highly innovative just in the state of Colorado. So throughout this, as a clinician, but primarily a researcher, I'm hearing a lot about sort of patient experience. I'm hearing a lot about some of the motivations, but also some of the challenges you face in your current infrastructure, and also thinking about expansion, which kind of ties in with one of the questions that's been posted, I think, pretty nicely. Thoughts on a future research agenda to understand either your work individually or the potential linkage of programs like FNEs and HVIPs.
I mean, Jenny, we probably could both speak up here on different research goals, but certainly we have a very active program of research that we are trying to build on and continue to grow and strengthen. A lot of the work we do in research has been looking at secondary outcomes, but I think with this navigator model, we've been able to produce different kinds of documentation. We have way more information than we've ever had about patient needs and resources, and also what our nurses and navigators can really do to mediate that hospital to community-based resource pathway, and then maybe how we could also work together with other community partners to strengthen that pathway of coordination of care. And so we actually just submitted 2 grants, and we are continuing to submit as much as we can, but part of this is a lot of it's quality improvement evaluation, but from a research standpoint, I think there's also a lot to be learned here and a lot of goals. We haven't don't have any active projects. We have some active projects of our patients already, but in terms of navigators, I think we're hoping to continue that and build in more evaluation and quality improvement. And then from a research standpoint, we really have an incredible ability to know as much as to know about our patients, but also be able to improve care for them because of what we're able to learn. I hope that answered your question. And then I have some
No, that's really helpful. I'll also sort of maybe pivot to Mr. Williams for a second. So you had mentioned in your opening remarks some sort of regulatory comments about HIPAA. I've also heard you speak previously about the importance of hearing the perspectives of the people we're caring for, but also some of the challenges in engaging them in research. And I'm curious if you have some thoughts on within that research agenda, what kind of questions we should be asking of the people we're trying to provide services to, or maybe the folks we're not even reaching with our services, or maybe what are some of the obstacles in engaging them in some of these sort of formal research efforts that we talk about within our grant applications.
Yeah, I'm gonna have to let Dr. McCarthy answer that because I think it's a setup from my standpoint. Because I always think that we already have the answers to the questions that we're asking our patients. I don't have a question that I need to ask. Someone came to us and said, "Hey, can we use your patients to find out like why are kids carrying guns? Because they're scared." What do you mean? Well, am I going to ask that stupid question? Right. So my thing about research is what is it that we're trying to know? What do we want to know about our patients that we don't already know? Right. And I know that some grant funds want us to have the data, qualitative and quantitative, and we can definitely go through that exercise. But like when it gets down to the real aspect of it, I need to know the root causes. Like we already know like some of the answers to the broad questions that they're asking, but like we never get down to the root cause and then the dissemination of the solutions. And our dissemination is implementation. So with our research projects, it's like if you're going to come to our community with a question that you already know the damn answer to, you better be ready to answer it with a dissemination of a solution as to how we're going to address said problem. But Dr. McCarthy, who is in charge of our research, can probably give you an answer that maybe the researchers on the line might want to hear.
Well, I think the answer is what you said, that we don't have a research agenda other than understanding, it's what Rachel said too. What was your experience like? What went well, what didn't go well? And to the implementation point, we have an in-house research team that is violence prevention professional led. And so my job isn't to lead the research agenda, it's to ask the team what we should be asking, how, why, and then what we do with that. Because if it doesn't change patient experience, if it doesn't change community access, then our research doesn't really matter anyway. It has to be practice oriented and it has to be experience driven. And so that's where our team comes in and says, here's what we're going to do. Here's what we need to know. We know the answer to the question at the surface level, but those root causes, why didn't you go back to care? Where would you feel comfortable accessing care? You didn't say yes to the F&E team for a forensic exam because you didn't know what it was, or you didn't trust them. Things that Felipe was saying, like, how do we get someone in the room who's trusted enough to share what could happen, what couldn't happen, what the implications are 3 steps down the line, so that people feel more comfortable. So research to know why people don't go back for care, we don't need to know that we know the answer, but to give research in such a way that it inspires people to go back for care, it inspires trust, it rebuilds and restores trust. That's the research that we need to do. That surface level doesn't impact really anyone, honestly, and it actually further breaks trust.
And then extrapolating that from the qualitative, the story, because the question that I usually ask is, at what point did the trust get broken? And that's going to be different for each patient. That engagement is going to be different for each interaction. And if we can extrapolate each of those interactions and answer that question for either the doctors that broke that trust, the police that broke that trust, the security guards that broke that trust, the charge nurse that might have broken that trust, just any interaction that they might have had that helped break that trust further, we take all of that out and we take those stories and we present that back and in a dissemination of this is how we should change. These are the areas, because there are some people who are in these systems who break trust, who don't think they have nothing to do with patient care. And I think that patient care starts when the ambulance picks them up from the scene all the way to the time they're back at their doorstep. And everyone plays a part in that. Right. So that's the research that needs to happen, is what role do you play in breaking the trust in a patient that is suffering trauma, and how do we fix that? Because you didn't think you had a role in it and you don't know the damage that you did.
I think that's where the community-based research and community-based care comes back in, because it is that restoration of trust. It is identifying that exact moment, because it might not have anything to do with this episode of care. It could have preceded it, and it could have been in multiple different arenas, but to be able to have the right people ask the right question in the right way, that the answer can be obtained in a way that is genuine by the right people, because if the wrong person asked, or the question's asked in the wrong way, we don't get the answers we need anyway. So for the community really to lead the response, I think is the answer across the board too.
All right. Well, thank you for that. I think that about wraps us up. I think that's the end of the questions that we have. Again, I want to thank everybody for attending today's presentation. I want to thank all of our presenters, and we look forward to seeing you at our next webinar series. Thank you.
Thank you, guys.
Thank you.
Thank you.
Good to see you, AIM team.
Thank you.
Yeah, great to see you guys.
Bye.